Hello, I'm Nicky Adrian. I'm a consultant child and adolescent psychiatrist and a senior lecturer at St George's Medical School. This is the third in a series of lectures that introduce you to child psychiatry. Today we're going to be talking about adolescence. In this lecture we're going to cover the key factors in the assessment of adolescence, which includes looking at assessment of risk, disorders that are associated with that, confidentiality and consent, as well as a focus on a specific example of an emotional disorder, school refusal. Contrary to popular belief, adolescence is not a psychiatric illness, although half of adolescents experience something that looks very much like one. There's mood swings, social sensitivity, sleep disturbance, grumpiness, etc. Adolescence is the transition between childhood and adult life, starting somewhere around puberty and ending, certainly from an emotional and cognitive point of view, in the mid-20s. Some of us might think that it goes on for much longer. During this period of time, an adolescent needs to attain a sense of independence and self-identity, and for the first time establish a sexual role and orientation, and to be able to learn to control aggressive or oppositional impulses that may get in the way of functioning. The overall prevalence of mental health disorders in adolescence is about 15 to 20%. Most disorders tend to be those that persist from childhood, and those arising de novo in adolescence tend to be affective or related to mood. They are also less causally linked to family dynamic factors and more often linked to individual factors within the child or the child's specific peer environment. The prognosis for serious mental illness developing in adolescence is not necessarily better than if it were to develop in adults. Some of the specific problems we may see in adolescence are, as I've said already, those that persist from childhood: school refusal, bullying, self-harm, depression, eating disorders, psychosis, particularly in late adolescence, substance use and antisocial behaviour. A key factor in assessing adolescence is to be able to get them to relax and to be able to tell you what is going on. You will always need to see an adolescent on his or her own unless there are exceptional circumstances. It is very useful to be able to explain the premise of confidentiality and the doctor-patient relationship to both the adolescent and their parent, as they may have different views. You do not want to lose your therapeutic relationship with an adolescent if you tell the parents something that they've told you in confidence. You explain at the outset by a simple sentence saying that everything that the adolescent says to you will be kept confidential. The adolescent is your patient rather than their parents. Obviously, depending on maturity and capacity, you may need specific consent to share things outside of the health system, for example with school. Need to inform them that you would have to share information if there was any suggestion of harm coming to the child or risk to a child's life or to others. After you've met with an adolescent, it's always useful to clarify with them what you will report back. What should we say to your parents? What can I tell your parents? Would you like to say it? Or should I? Is there anything that you don't want me to tell your parents at all? If they mention something that you feel is an automatic disclosure, you will have to tell them that you will be saying that to them and possibly rehearse with them how you might want to do that.